Everyone, and thank you so much for joining the NCCN Global Academy today. My name is Tracy McDowell. I am the Manager of Global Business Development here at NCCN. I'm very pleased to have you joining us today. I see some of you in the Q&A have shared which country you're joining us from. We'd love to see that. We'd love to see where everyone's coming to us from. And I would just like to take a moment before we start today's panel to briefly introduce a few of our key global initiatives that you'll be hearing more about today. Many of you have heard them before, some this may be new to you, so I'm just going to give a quick brief overview of what differentiates them from each other, and then I'll hand it over to Dr. Carlson to begin. So we're today going to be talking about, and Mark, you can move to the next slide, please, thank you, the regional adaptations of NCCN guidelines, the NCCN framework, and the NCCN Harmonized Guidelines. So again, our focus here is just always awareness, accessibility, and relevancy of NCCN resources around the world, no matter where you're located, to help improve cancer care. Let's start with regional adaptations. So these are NCCN parent guidelines that account for metabolic differences in populations. This is done for mid to high resourced regions. They're created in concert with local in-country physicians, and they are less extensive than those needed for regions with less resources. This is a one document where adaptations are highlighted in green. Currently, we have adaptations for Asia, Latin America, Middle East, North Africa, and Spain. Next is the NCCN framework. So these are separate guideline documents specific to resource level, not region. And Mark, you can move to the next slide for me. Thank you. So this is a global tool for physicians in low to mid resource settings. I'm just going to briefly go over each level, which is basic. These are essential services needed to provide basic minimal care. Core includes basic, but also additional services that provide major improvements in disease outcomes and that are not cost prohibitive. Enhanced includes both basic and core, those already mentioned, and additional services that provide major improvements in disease outcomes but are cost prohibitive in lower resource settings. And then we have the NCCN parent guideline, which is evidence-based, consensus-driven recommendations made by NCCN panels. These are what you know, and these are our main product. Currently, we have 19 NCCN frameworks, and that's growing constantly. Finally, we have the Harmonized Guidelines. So NCCN took the concept of resource stratification from the NCCN framework and created a color-coded, region-specific single document. Mark, you can move to the next slide, and we'll have an example there for people to see. So this shows the optimal level of care, which is our NCCN parent guidelines, as well as pragmatic treatment based on available resources. So the next slide shows the Sub-Saharan African Harmonized Guidelines were created in collaboration. Next slide, please, Mark, thank you. With the Clinton Health Initiative, the IBM, American Cancer Society, the African Cancer Coalition, and NCCN. So currently we have 47 published harmonized guidelines for sub-Saharan Africa. We are really pleased with this collaboration. The NCCN harmonized guidelines for sub-Saharan Africa are also importantly endorsed by federal ministries of health and leading cancer centers in Ethiopia, Malawi, Nigeria, Tanzania, Uganda, and Zambia. And that represents 43% of the population of sub-Saharan Africa. And again, these published we're constantly adding to this guideline library as well, which we're really proud of. You can move to the next slide, Mark. Again, this shows the Allied Against Cancer Coalition, which includes the groups I've just mentioned. We're very proud to be a part of it. We're very proud of the work that's been accomplished and that continues to be accomplished even in the midst of a pandemic. NCCN is actively seeking support for our global initiatives. So if you or your team would like to learn more about any of these or our global initiatives, which I haven't mentioned today, please reach out to me. please reach out to our team. We would love to have these conversations with your team just to let you know what we have available. And also if you're interested in perhaps sponsoring some of our initiatives as well. We're always looking for support. So now that you've had a primer on these initiatives, I'd like to hand the program now over to our NCCN CEO, Dr. Bob Carlson, who will be moderating today's panel and introducing the rest of the panel members to you. So thank you, and I'm happy to hand it over now to you, Dr. Carlson.
Great, thank you, Tracy. Please let me add my welcome to this panel discussion on NCCN Global Resources. With me on the panel are oncology experts, all of whom have participated in the development of a variety of NCCN Global Resources. This is your opportunity to learn from the experts about the generation of NCCN Global Resources, and importantly, to ask participants your questions about the NCCN Global Program. We will aim to leave time towards the end of the panel discussion for questions and answers. And so please use the Q&A feature or function on Zoom. As Mark said, you can get there by hovering your mouse over the bottom part of the screen. Submit those questions and they will be in turn forwarded to me for submission to the panel. So I'd like to start today's panel by having each of our panelists introduce themselves. Please give your name, country, organization, professional role, and how you have participated in the NCCN Global Program. So let's start with Dr. Abdul Rahman Jazieh. Dr. Jazieh.
Thank you, Bob. It's nice meeting all of you. It's a pleasure to be with you in this important event. I'm a medical oncologist by training, the chairman of the oncology department at King Abdulaziz Medical City in Saudi Arabia, Riyadh. We participated in the adaptation of NCCN guideline to the Middle East and North Africa since 2009, and we established the NCCN Collaboration Center in 2010 for the Middle East and North Africa. And we did adapt guidelines multiple times over the years. And I appreciate the cooperation and the support of the NCCN team and leadership.
Wonderful. And let's hear next from Dr. Susan Msadabwe. Susan?
Thank you, Bob. Hello, everyone. I am Dr. Susan Msadabwe from the Cancer Diseases Hospital in Zambia. I'm a clinical oncologist by training, and I'm the head of clinical care at the Cancer Diseases Hospital.
Wonderful. Thank you.
I'm a member of the African Cancer Coalition, and I participated in several of the harmonization of the guidelines. Thank you.
She's being very modest. She's participated in multiple of the harmonizations. Next, let's hear from Dr. Susan Spencer. I'm sorry, Sharon Spencer.
No problem. Good morning, everyone. My name is Sharon Spencer. I'm a radiation oncologist at the University of Alabama, Birmingham, at the O'Neill Comprehensive Cancer Center. I've had the pleasure to work with the head and neck panel for several sessions. It's been incredibly enjoyable. I've learned so much. It's been a wonderful opportunity, and I'm glad to be here today.
Wonderful, thank you. And next, let's hear from Dr. Andrew Zelenetz. Dr. Zelenetz.
Hi, I'm Andrew Zelenetz. I'm a member of the lymphoma service at Memorial Sloan Kettering Cancer Center, and I have led the B-cell lymphoma guidelines for a number of years, and I participated in all flavors of the global process with adaptation of guidelines for use, lymphoma guidelines for use in China, in MENA, and the harmonization process in sub-Saharan Africa.
Great, thank you. And Dr. Wui-Jin Koh. Dr. Koh.
Sorry. Yeah, good morning. My name is Wui-Jin. I'm a radiation oncologist by training. I had treated gynecologic and gastrointestinal cancers at the University of Washington Fred Hutch for about 30 years, but had the opportunity to join NCCN just about 2 years ago as Chief Medical Officer. I had previously been a member of the Pancreatic Cancer Panel and also the Gynecologic Cancer Panel that covered cervix and uterine cancers, and have had the great opportunity of being involved in the Frameworks program about 5-6 years ago when that got started, as well as the Harmonization program in Sub-Saharan Africa, as well as in the Caribbean and Latin America. And I have been very impressed in all these interactions with the knowledge and the desire and the motivation of all of our global partners.
Great, thank you. Dr. Jazieh, perhaps you could kick off the start of the meat of this discussion. Tell us about your practice environment and your motivations for creating the Middle East North Africa guidelines. Your organization was really one of the early organizations to participate in this process, and you have a long history and experience with the effort.
Yeah, thank you, Bob. So it's actually, this started in around 2009 with a large regional meeting that was led by NCCN in Abu Dhabi, and we did the declaration of Abu Dhabi that was published in the JNCCN, highlighting the importance of adapting these guidelines into regions. And then from there, we picked up different diseases. We formed committees, and we did describe the steps of how we need to adapt the guidelines, basically focusing on the differences in any genetic or metabolic or information that we have in the region, and to make sure that this is suitable for our practice in the region. As you know, the region, there is difference in the economic status of the countries of the region, but we try to maintain a common ground of having the guideline as close to the parent guideline as possible, and we changed the essential thing that we felt that needed to be changed in the region. And it has been actually, the exercise has been terrific in many ways, including actually identifying many of the deficiencies in the region that we needed to work on and identify. And actually many collaboration came out that we can mention later, and many initiatives came out from this. But the most important thing actually is the expertise that developed in the region and how to look at the guidelines thoroughly and how to adapt it in a structured way. And as I always say that, actually, and we can expand that later, if I want to say what is the most important skill, number one skill that physicians, oncologists specifically need to have nowadays is how to adapt guidelines. Because we adapt them not just for a regional level, we adapt them for even institutional level, we'll mention that later, but also we adapt these guidelines to individual patients. All the time we do this adaptation that, I believe this is important skills for all physicians to acquire.
Great. Dr. Msadabwe, tell us about your practice environment and your motivations and the motivations from your colleagues in Sub-Saharan Africa for creating the Harmonized Guidelines. You're on mute, Susan.
Sorry about that. Thank you. Yeah, so my motivation, first of all, I think is about that cancer patient who we need to ensure that that patient has decreased morbidity from cancer, to ensure that patients in our region get the best of care with the resources that we have available. As Jazieh said, that the resources that we have available might not be the ones that are in the parent guideline. Therefore, we have to adapt the guidelines to our setting. There are a few kickbacks as well from this main motivation, which is increased collaboration within the region, which could lead to research opportunities it could also lead to increased availability of access to quality and affordable cancer medicines, as well as equipment, as everybody in the region, because of the same guidelines being used, will be ordering the same equipment or cancer medicines. So I think that's my main motivation and our main motivation as a region. Thank you.
Mm-hmm. And why did you choose to adapt or harmonize the NCCN guidelines as opposed to creating your own guidelines from the ground up?
So we chose to solve different areas were developed. Well, some were in the process of developing their own guidelines, but as you know, as NCCN, that developing guidelines is quite resource intensive. And we know that cancer care is an evolving field. And therefore, it's not only the development of guidelines, but also updating of the guidelines, which will need to be done, which in our environment also would be very difficult to do because of the resource constraints. And in addition to that, what was done at the beginning of the exercise of harmonizing the guidelines for sub-Saharan Africa is a survey was actually conducted among the region to see which guidelines are used by sub-Saharan Africa. And it was actually found that NCCN were one of the highest used guidelines, and therefore it was imperative, obviously, to use the NCCN guidelines since a lot of people were familiar with them. And also them availability online on a tablet or on a phone made them more user-friendly as well. So I think that's what I would say about that. Thanks.
Okay, great. And Dr. Jazieh, why did you choose to work with NCCN as opposed to another guideline organization or to develop your own guidelines from scratch?
Yeah, okay. So actually, you know, adapting the NCCN guideline, adapting guideline in general. So there are three ways of doing, taking guidelines. Either you create them from scratch, which it's cumbersome and difficult, and even major organizations are not able to keep up with that. And that's why you find organization publishing guideline, and then after a few years, they don't update it. The second thing is you adapt guideline, which we choose this route. And the third thing is adoption. You take the guideline as they are and they say, these are our guidelines, and you don't do anything with them except take them as they are. So adaptation of NCCN guidelines specifically because they are up to date. So some of the recommendation comes online within 2 weeks from major breakthrough studies. And some diseases like in lung cancer, you may find 7 or 8 versions a year. So that's, you know, that tells you that these are updated guidelines and they are comprehensive. You know, they cover the most common scenarios. They don't leave the practitioner struggling with difficult decisions and difficult situations. So you see the spectrum of the disease covered throughout the disease trajectory. So this is very critical. And then they are accessible, you know, easily accessible. And actually, we did survey and we published it in the Journal of Global Oncology with David Kerr. And we did like 140 oncology leaders worldwide. And 92% of people use NCCN guideline compared to 55% using other guidelines such as ASCO or ISMO guideline. So it is you know, reflection of the NCCN guideline feasibility, accessibility, and comprehension, and you know the most important thing, the up-to-date kind of thing, which is very difficult for any organization to keep up. And NCCN has been doing a tremendous job in that.
Well, having worked with NCCN for many years, I can certainly tell you that developing and maintaining the guidelines is not an easy task. It's very time consuming and requires a hugely dedicated staff to be able to accomplish that. So Dr. Koh, we have a library of NCCN clinical practice guidelines for use in high resource environments. How does the process work to take those guidelines and to either adapt them for an area like Middle East, North Africa, or to harmonize them for Sub-Saharan Africa? How do you do that?
Sorry. If I can add one other thing to what you just said, Bob, about the dedication of our staff. We also have 1,500 volunteer faculty members from all of our member institutions that have donated a tremendous amount of time and effort. But coming to your question of how one adapts and creates harmonization, there's sort of things along a spectrum, as Tracy has perhaps mentioned. In areas where there is a pretty good access to care and resources, like in Middle East and North Africa, based on the interests of groups led by Dr. Jazieh, or in the Eastern Pacific, they ask, first of all, it's at the request of the local or regional organization. NCCN doesn't go to a place and tell them that they need to use NCCN guidelines. They have to recognize the value of it. And they come to NCCN and say, well, can we use the content process that you have already and modify it for this, the differences in, as Dr. Jazieh said, metabolism, education, and availability. So that's the adaptations, and the adaptations have very limited changes from the parent guidelines. Regarding the frameworks started out of a process through the Breast Health Global Initiative, and something that Dr. Carlson, you and Dr. Anderson started to recognize that the guidelines that are made by most organizations historically have been geared towards high resource countries, North America, Western Europe, but recognize that this were not perhaps relevant to places where they did not have access to, whether it was imaging modalities or treatment modalities. And so the frameworks provided a system of thinking as to what could you do when those various resources were not available. And Tracy has outlined the 4 different levels of the frameworks. The frameworks are created predominantly from experts in the United States and are vetted by international collaborators. What we found was that the framework provided, if you will, a structure to think. They could be useful, but when we came down to where the rubber met the road, as in, for example, Sub-Saharan Africa, we again had to ask experts like Dr. Susan, what can you do? What would you do? And how would you prioritize things? So rather than having 4 different documents, the African Cancer Coalition wanted to create a single document that reflected the spectrum of care and to be flexible in how that information is presented to its users. And the goal in all of this is to not only allow for some variation in care depending on the level of resources, but also to keep the context of the NCCN parent guidelines to use as an educational instrument and also as an advocacy instrument with their ministries of health to seek greater support.
Great, thank you. Thank you. Dr. Spencer, could you talk to us about or share with us how evidence is considered and what kind of evidence is used in developing the harmonized guidelines or adaptations? Where does it come from?
So,
how is it considered?
Yeah, so very good question. So I think, as you said already, medicine and especially cancer research is very fluid and ongoing. There are breakthroughs and trials being done nationally and internationally that are important to highlight and keep in the forefront of making decisions about guidelines. So we try to use high-level evidence. And as you know, the NCCN has developed sort of a stratification for how we consider evidence. Is it level 1? Is it level 2? And that is, printed and documented within the guideline system itself. So we try to look at the best evidence available and also to look at best practices amongst the institutional members. And then bring all of these facts together. There's a structured vote on adoption of the guidelines that we print and publish. So it's a very standardized, very organized way of looking at the data as it becomes available. And as you mentioned, it comes rapidly.
Great. Dr. Zelenetz, anything to add to that in terms of how evidence is considered and where it comes from? And you're on mute, Andy.
No, I agree with Dr. Spencer. With certain areas like lymphomas, one of the things that actually is a challenge in the Harmonized Guidelines is establishment of a diagnosis, because we're only as good as our diagnosis. The treatment, if you're treating the wrong disease, you're going to not do as well. And so as good as our evidence-based is, and we need to establish a good diagnosis. And so the resources around diagnostic capabilities turned out to be a critical aspect of the harmonization of the lymphoma guidelines. Then when it comes to evidence, of course, we're looking for the biggest delta, a treatment or an approach that has a relatively minor improvement, but at an enormous cost. That is, even though there may be evidence for it, that is less important than when there's a large delta in outcome. Great.
Dr. Jazieh, Dr. Msadabwe, anything to add to how evidence is considered by your panels?
Yeah, for our region, we look at what is available data from our region that may, encourage us or, entice us to try to adapt the guideline to our region. And sometimes it's just a certain practice pattern that, as a consensus, we agreed on it as an expert in cancer care. For example, if somebody turned out to be positive for mutation after starting chemotherapy, the whole panel, for example, did not feel comfortable continuing the maintenance chemotherapy and decided to switch early on, either maintenance switch and so on. So we can sometimes, if there is an evidence that, from our region in terms of, the data, and then if there is practice pattern that will be more suitable to our region because of the patient's characteristics, the loss of follow-up, less tolerance of chemotherapy and so on. So we decide based on that.
Just in addition to all the panelists, I think I agree with what everybody has said. In our region, research is very limited, and therefore there's not evidence for our region. However, I'll highlight for the Kaposi sarcoma guidelines that the data, because Kaposi sarcoma is very common in our region, the data for sarcoma guidelines was actually available, and a lot of it actually came from our region. And initially, there was actually no Kaposi sarcoma guidelines in the NCCN, and we decided as the African Cancer Coalition that because that's one of our commonest diseases, we needed to have it. And from there on, as we started with the guidelines for our region, I believe that NCCN went ahead as well and then developed the guidelines for Kaposi sarcoma.
Yeah, I want to second that. This is also a testimony for the openness of NCCN, and I think Dr. Zelenetz, you remember that about introducing subtype of lymphoma from the Middle East into the NCCN guideline for the adaptation, then it was incorporated into the parent guideline. So this is a very important characteristic of the NCCN, of being open to ideas that, they can improve their parent guideline, and they adapt it when they find it suitable to be adapted.
So I was going to mention that. So we had HTLV-associated lymphoma is a problem not just in MENA, but it's a problem in the United States and other parts of the world. But the expertise was actually deeper in the MENA region than on the NCCN US panel. And this was a very fruitful exchange, and we got a tremendous amount of help and input, and that helped improve the parent guideline from the interaction. And this is true, I mean, even at every level, because when there are more people reviewing what you're doing and asking questions, why something is in a guideline, why something's not in a guideline, that just helps improve the process. All the interactions, it may not be introduction of a new guideline or dramatic improvement of a new guideline like it was with HTLV-associated lymphomas, but all of the interactions have resulted in refinements and improvements to the guidelines because of the bi-directional discussion.
Bob, may I also add one thing here? When we go through the harmonization or the frameworks process, it is not just, quote unquote, removing options that are not available based on resources. There are also options that are uniquely added that are feasible in these areas, but they still have to be based on evidence. As Dr. Susan Msadabwe will note, we have in sub-Saharan Africa given the option in locally advanced cervical cancer for neoadjuvant chemotherapy followed by surgery, whereas the standard of care is acceptably chemoradiation. But that is actually, that approach, while we recognize is not quite as good as chemoradiation, is still supported with curative intent by 2 large randomized trials, one in Europe and one in India. So again, to your point, even when we modify it, we do need to look at the data in support of the modifications.
May I add something here, Bob?
Of course.
Generally variation in practice is not good, is not recommended, and this is part of the quality improvement things, is to remove variation. However, sometimes, when you do systematic variation based on thinking in advance how to do it, that become, acceptable kind of variation rather than everybody do it however it comes to his mind and so on. And we encounter a situation that even affluent country with high resources, they were overnight limited in resources with the COVID-19. And if they have a system on how to adapt this, how to shift in different framework, that will be a structured approach to variation rather than everybody struggle on his own how to do in particular situation.
Great. So I'd like to follow up just a little bit on what we're hearing, and I can tell you I've experienced it, is that the exchange of expertise goes in both directions. The people that we have worked with reproducibly outside the United States to adapt or harmonize or modify guidelines, they are absolutely experts. They have a huge wealth of experience. And Dr. Msadabwe commented on the Kaposi sarcoma guideline that the first NCCN version was a harmonized guideline from the Sub-Saharan Africa project. And I actually had the privilege of participating for 2 days with 7 or 8 experts in Sub-Saharan Africa on Kaposi sarcoma. They see a lot of Kaposi sarcoma. And so they have a huge, huge experience. And I participated in that group not because of any expertise in Kaposi sarcoma. I haven't seen a case of Kaposi sarcoma in probably 30 years. but I was there as more of a process person, a guidelines person in terms of how do you put it together. I have to tell you, I walked away from that 2-day meeting just totally impressed with the expertise of the physicians and people who were participating with us in developing that guideline. And Dr. Msadabwe is correct. NCCN then later developed a Kaposi sarcoma guideline. And as our panel was doing that, they actually did it independently, although they were aware of the Harmonized Guideline, and I'm sure that they had reviewed it. We were terrified that at the end of the day, that the two guidelines would be very different. It turns out that at the end of the day, the two guidelines were almost identical. So it's you know, we have to respect the expertise of individuals around the world. So I'd like to change the topic a little bit. We've talked about medical issues, scientific studies, and that sort of thing. But all of these processes, these guidelines within regions, are impacted by governments. They're impacted by payment systems, in who pays for care and what among the care is paid. You know, in the United States, we have 50 different states, but we have one federal government, I think, that sort of sets the standards or the stage for what the states are expected to provide. So there is an expectation, there's commonality among our states, more commonality than not in terms of what's covered and how the systems work. Within Middle East, North Africa, I mean, you've got a huge spectrum of governmental systems. I assume you have differences in payment systems. Certainly my experience in sub-Saharan Africa is that the payment systems vary greatly from country to country. The resource levels that the countries have, and each of those countries actually also has different regulatory environments in terms of what drugs are licensed or are available. Huge problem. How do you deal with that as you're trying to develop guidelines that are regional based across multiple different governmental boundaries? Dr. Msadabwe, do you want to try to start with that one?
Yes, very important question, very difficult to answer. As you said, the region is very varied, and even within the same region, the resources are also very fluid from time to time, depending on what the country is undergoing and the political environment, etc., etc. So very, very different. So that's why for Sub-Saharan Africa, for the African Cancer Coalition, as you said, we decided that we will go with what we called resource integrated guidelines, or the harmonized guidelines as they are known today, such that within the same document, I am able to utilize the same document today with the resources that I have today that might be different from what I have tomorrow. So as you said, it's very varied. Some countries will actually pay for cancer medicines for the patient, with the patient not taking out any funds from their pocket. Some countries actually have health insurance. Most countries don't have any health insurance whatsoever, though the number of countries that are beginning to have national health insurance are increasing, but a lot of these again actually don't cover cancer care. So yes, it's very difficult, but we have to do the best with what we have. Thanks.
Yeah, I think the fact that you mentioned, Bob, about the different stakeholders that look at the NCCN guideline, actually that may be a blessing. Because actually, if you look at every country, no matter what is the healthcare system, you find all these scenarios. You find different scenarios. So for example, even in the same institution, let's say today I have a surgeon who does this sophisticated procedure. Tomorrow he leaves the institution. I don't have material for the PET scan. The PET scan all of a sudden is not working. Giving you an example of things that may change, even in the same institution. but also for individual patient. The fact if you are from a country that have limited resources, the individual patient may have access to resources, may be able to purchase the treatment, may be able to seek treatment somewhere else and so on. So the fact that they have these options that people can go through, so what we have to do, we have to make sure that we make the guideline as satisfactory to, in our region, I'm not talking about the harmonization, satisfactory to a high level of care, and then teach people how to adapt it to their individual situation and individual institution status, because as I said, even in affluent country, you may have people covered, you may have people who are not covered, you may have patients, they make strict criteria about accepting certain medication, while other individual patients may be able to get that medication. So that's why I have said earlier, one of the important skills for physician is to learn how to adapt the guidelines up and down based on individual situation, whether institution or even individual patients. But we kept our goal is to make sure that we change the guideline only when you have something compelling to say, okay, for our region, this is probably not the best recommendation or the less suitable for our region. And we left it as close to the parent guideline as much as possible because we need this variation. We need this variation and these options.
Is there much movement of patients across international boundaries in these regions for care? I know that in sub-Saharan Africa, for instance, radiation therapy equipment is in limited supply, although that's improving rapidly at the current time. But do patients travel much from country to country for care, and can guidelines help at all in helping to standardize care across national borders?
Yeah, yes, they do. They do in the same country, and sometimes, although to less degree lately, they travel to international sites. So they may leave, especially from other Gulf states, they may be going to the Europe or United States and so on. And actually that may help in the discussion if the physicians say, this is the treatment, this is what we can do here, and this is what you would be getting in the US. These are the options you'll be getting in the US. And that may be a driver for certain patients, and justification, by the way, for certain patients to get acceptance and get referral actually officially to go and get treated. So let's say we have a treatment recommendation in NCCN that cannot be done in the country. We actually give the physician may give even the support letter to the government to allow the patients to go somewhere where it is available. So that's why there's something very critical that we mentioned in our paper that was published in 2018 about adapting the framework. You have to know what is the level of compromise that you can step down before you're referring the patient to other centers. So if I'm going to go down to a lower level strata, the lower level recommendation, what would I lose? And then if the patients travel 20 kilometers or 100 kilometers and he will gain this 5%, would I recommend him to travel there? So that's very important to keep in mind, when you are adapting guidelines into stratification. So you always have to ask yourself as physicians, when I go down, what would I lose? And if there is somebody nearby, or it depends, or not nearby, but the patient can afford to go and get the treatment there, can they go and get it?
Great. I think one of the reasons for such wonderful success in sub-Saharan Africa, and probably one of the major reasons for so many of the health ministries and major national cancer centers endorsing the Harmonized Guidelines, is the fact that we've had representatives from several of the health ministries in sub-Saharan Africa who actually participate in this process. And one of the initial founders of the African Cancer Coalition, Dr. Isaac Adewole, is himself a surgeon. And at the time that the whole initiative started, he was actually the health minister for Nigeria. And he continues to be involved. He's a very highly respected academic surgeon in sub-Saharan Africa, and and I think has a fair amount of respect among the health ministries from the sub-Saharan African countries. So, you know, involving the multiple different stakeholders, including those people who, in general, hold the purse strings, can be extraordinarily helpful to this process. That's great. Dr. Koh, how has the development and implementation of these sort of global initiatives evolved over time? Is it a static process? Is it changing? What's going on with it? And importantly, how in the world do we keep these guidelines up to date?
Well, as someone's already attested to, you know, it is a challenge, but that's something that is in NCCN's forte. So no, it is something that has evolved. When we developed the first set of, say, harmonized guidelines in sub-Saharan Africa, it took 2 meetings over a period of 6 months, and Dr. Msadabwe was involved in that. Over time, that cadence has gotten much more rapid because we've understood the process, we've understood each other. We've learned from, as you mentioned, from the sub-Saharan African experts as to their level of comfort, their level of expertise, and I shouldn't say their level of expertise. The level of expertise is outstanding, but more what is feasible, so that over time, we've become much more adept at developing these, for example, harmonized guidelines. And in a little over 2.5 years, as mentioned, we now have 47 guidelines that are harmonized in sub-Saharan Africa. This is out of a universe of 79 total parent guidelines. So we have about 2/3 of the guidelines already harmonized in sub-Saharan Africa over a relative short period of time, and not just for treatment, but also for supportive cares and special populations. And we've taken what we've done in sub-Saharan Africa and applied it to other places. As you know, in the Caribbean, we were able in short order to harmonize 5 or 6 different guidelines, and we look forward to expanding on that. The process of updating is challenging, as mentioned by several. We do update the parent guidelines in relatively short order. Within, our goal is 2 weeks or less of major drug approvals or new findings. This is a little bit tough to do for some of the international editions, if you will. We have decided for pragmatic reasons to update the harmonized guidelines for sub-Saharan Africa, for example, on an every 2-year basis, unless there is a significant change that would impact care on a very sort of global level. Most of the updates that we have with the NCCN guidelines are for new drugs and agents, for example, that we recognize are perhaps not going to be available in resource constrained settings for some period of time. So a new NTRK type treatment or a new RET inhibitor, those may not be available quite yet. But in terms of a change of surgical approach or some basic changes, we will break that 2-year cycle and update in real time.
Anyone have anything to add to Wui-Jin's comments about the process over time, how it's evolved? We certainly are becoming experts in terms of Zoom.
So yeah, I think, you know, keeping up with the NCCN adaptation also will be, you know, difficult, not just for the sub-Saharan Africa, for any other entity, including the MENA. So we adapted, you know, once a year the guidelines, and then if there is anything major that we communicate among the group and see if we need to update it sooner. So because it's, you know, the NCCN does tremendous job in updating in a timely fashion. There is it's going to be challenging for any entity to keep up with that for all the changes that happen.
Great.
Yeah. Yeah, I think the updating process has improved over time. I remember for the first update of the cervical cancer, harmonized cervical cancer guidelines, we actually met in person, though we were adapting another guideline. But since then, we have become, as you said, experts in Zoom. So we do a lot of updating online. First, we go through the guidelines as the African Cancer Coalition, and we provide our input via email, and then we have our Zoom meeting, and that's how we go through the process. But I must say that it has become quite efficient over time, thanks to the NCCN as well as the American Cancer Society that provides some of the support.
May I add, in fact, carrying on what Susan, and as you asked Dr. Carlson about how to effect these, given the various regulatory processes and governmental agencies, I think our international program is to a great degree dependent on sort of visionary leaders and champions. And as you've mentioned, Professor Isaac Adewale, Dr. Jazieh, and Mina, and then one of the reasons we've gotten better is because of the efforts of these individuals like Dr. Susan and Dr. Jazieh, who do a lot of the preliminary work in looking through the guidelines, vetting them, looking for potential changes, and then suggesting that to us so that we don't necessarily start from scratch each time. So there is a cadence of familiarity and trust in the process. And one last thing I should mention is that we've also learned in Sub-Saharan Africa that this is not just a single institution of NCCN going in. We've learned the benefits of working with American Cancer Society, Clinton Health Initiative, IBM, and obviously the African Cancer Coalition. It's actually a multi-organizational approach rather than each organization going in and trying to do its own good. That combined approach, I think, has been very informative and wonderful.
So can I expand on this a little bit about the process, because very important, and I would advise our viewers to look at the publication that described the adaptation process that was published in 2018 in NCCN, and the initial simple way of doing the adaptation, at least in terms of the communication between the panel. So very important to have a multidisciplinary panel from the region that they are going to tackle guidelines. Like any good guidelines, it has to be a multidisciplinary panel. And then we ask the panel, we send them a form and saying, look at the parent guideline and then see what you want to change based on the recommendation. And then what is your justification? And then if you have reference and so on. Then we compile all these recommendations. Then we meet as a group first and we discuss it. We make sure that we come up with a final recommendation. And very important step, we meet with the chair of the NCCN committee for that disease. And we discuss the points, the suggested modification point by point to make sure that we understand the spirit of how this recommendation came to the NCCN guideline, just in case we are missing something. And then also we try to discuss our points of reaching this recommendation. And then we reconcile this into a final recommendation that is published in the NCCN website. So this is very important steps to know that there is regional work has to be done by a team, not individual, that it has to be vetted through the process, understanding that you agree on the recommendation, but NCCN also has the expert who review this modification, discuss it, and then come up with the final adaptation. So this is just an overview of the process, if somebody interested to know more details about it.
That's great. So Dr. Zelenetz, one of the criticisms that I hear not infrequently about all of these processes are that what NCCN is doing is endorsing substandard healthcare, and that we should not be doing that. Have you gotten that question? And if so, how do you go about answering it?
Well, yes, we've gotten that question, but I think, you know, Dr. Jazieh said it well before. You know, the goal of a guideline is to try to provide the best possible care, you know, within what can be given to a patient in a given situation. The resources within MENA do vary, and the guideline reflects that to some degree. The resources in sub-Saharan Africa are even more varied, and the harmonization reflects that. What we're trying to do is identify the most important aspects of care, make sure that they are done as the critical thing, and so that, you know, providing guidance to improve the quality of uniform care is not endorsing substandard care. It's ensuring that the resources available are used to the optimum way so that patients are best treated within the limits of what is available. You know, it is not a guideline's role to undo all of the inequities in healthcare across the world. We can't do that. But what we can do is we can try to identify those critical aspects of healthcare that maybe we would put in the non-negotiable frame to others that are, yes, if something's available, it's nice, but it's not essential. And, you know, this is not compromising, this is not endorsing substandard care. This is providing the best possible care within the limits of what's available.
If I may add also, this is a very important point to recognize that NCCN guideline has the level of evidence beside the recommendation. So it's very important, you know, those who are reading these guidelines, they see. So NCCN will not put for expert opinion as level 1 evidence. They will not. So the evidence there is clear, stratified, clear. So if you know, if they tell you if you did not put level of evidence, is 2A. They put category 1. They even put preferred. So that means there's no manipulation of the level of evidence. That's very critical, very important to know. And if we are going to practice level 1 evidence, 98, let me be even conservative, 85% of the things we are doing in the clinic will not be able to do it if we are going to practice level 1 evidence. Because not everything we are doing as oncologists has level 1 evidence. So you have the options, you have the level of evidence beside this option. You know, you have good level randomized trial for these 10 regimens of chemotherapy. They all have randomized study. Why you don't list them all? This is the apparent guideline. You have to cater to all the people who potential user of this care. So this regimen, 12 regimen, have phase 3 studies, and you know they are the same level of evidence. You list them, and then that allows the physician who have access to any one of these regimen, based on his clinical judgment, to use it. You know, so that's very important aspect of and like any other tool, it's all depending on the user. You know, this is very critical to keep this in mind. You know.
Great. So, Dr. Zelenetz, I know that you've had a longstanding interest in the use of biosimilars in oncology care, and have some pretty strong feelings about how biosimilars should or shouldn't be incorporated into oncology practice. How does NCCN consider the biosimilars, and how does that consideration of biosimilars translate into issues of regional adaptations and harmonizations?
Well, as you know, we've been, as an organization, the NCCN has been interested in biosimilars long before there were biosimilars. We had a task force to try to identify the critical things that pharmacologically, medically, we thought were important. We published a white paper. Interestingly, many of those issues have been adopted by the guidance from the FDA. But what we now see is that the EMA and the FDA have adopted quite rigorous guidance for what is a biosimilar. Ironically, there are molecules available today that would not meet biosimilarity comparisons compared to when they were first marketed 20 years ago. So the concept that, oh, this is a biosimilar, it can't be the same. By definition, two lots of biological drugs are going to be somewhat different. But because of the biosimilarity exercise, largely preclinical, we really have been able to identify that there are no clinically meaningful differences. And, you know, the availability of biosimilars is critical for price competition, and it's very important for global health. So the NCCN has, after careful consideration, adopted, incorporated both therapeutic and supportive care biosimilars into the guidelines, and that allowing them to be used, that you can use a biosimilar or the originator compound, depending on what's available locally. And these recommendations are also in the regional and harmonized guidelines.
Great. A little bit along the same vein. So the NCCN guidelines have a number of different therapies or resources that are not available around the world, and that's why the adaptation in part and the harmonization efforts in part are performed. Have the guidelines in either of your two regions, Dr. Jazieh or Dr. Msadabwe, been used to go to health ministries and say, look what we could do if we had this additional resource in terms of care for our national population of cancer patients? Are they used for lobbying efforts with health ministries?
So I can start. We have not done that at a ministry level. We have done that at institutional level, which is, big, large organization, and whenever we are asking drug to be added to the formulary or something, we attach usually the guideline, the NCCN guideline, and you say, look, this is now in a very credible guideline that, we use it as primary source of guidance. And then we have been successful in doing that. And, many of the organizations follow the same scenarios. Since there is not clear national guidelines in terms of medication, what to give and what not to give, it's basically mainly institutional thing. And once the institution gets the approval to use a certain medication and treatment, usually the government sponsor them, at least in Saudi Arabia. In different countries, the Gulf states always, probably in the similar fashion. So that is, the approach we use. It did not reach yet the governmental level, like probably in sub-Saharan. So I'll hear what Susan will say.
I think our situation is more like yours as well, Jazieh. I think we have used the guidelines more on an institutional level. We have made recommendations at an institutional level which have been approved. And our recommendations at institution, because we are, for instance, I'm giving an example of Zambia, because we only have one comprehensive cancer center in Zambia, those are the recommendations that we provide at the institution, but then that go to the Ministry of Health. So yes, in a way, we have done to the Ministry of Health through our institution, but we are actually planning to do it on a more broader level, in that we'll be opening other centers in other parts of the country as well.
Yeah, actually, I can add, sorry, to this. Now, there is a movement, by the way, to purchase the cancer medication centrally, and the whole panel that, was put to recommend these medications, they've used, the NCCN guideline, as justification for these medications recommendation.
So, Dr. Msadabwe, so Zambia is one of the countries where the health ministry, I think, has endorsed the Harmonized Guidelines. What does that endorsement mean? What does it do? What are the implications of having governmental endorsement, health ministry endorsement of the Harmonized Guidelines?
Okay, so the endorsement means that the government recognizes that that's how we should treat patients, all as doctors. So we are responsible to treat patients according to the guidelines. That's one. Two, then the government will recognize, for instance, that those medicines and equipment that are in the guidelines are the ones that will need to be made available for use in the health system. That's another way that, yeah.
Okay.
As well as, okay, one thing I forgot to mention as well is for training. I mean, we are a training facility as well, and we need to ensure that all of us are training. I mean, we are imparting knowledge that is similar for people who will take over from us. So that's another way that the endorsement is taken. Yeah.
Okay, good. So I'd like to change subject a little bit now, from sort of, again, the scientific, medical, and regulatory things to the personal issues and so forth. So, Dr. Spencer, you've participated now in the sub-Saharan harmonization effort and generated several guidelines. Thank you very much, and have continued some of those relationships through updates and so on of the head and neck harmonized guidelines. So, talk to us though about how the experience has impacted you, what your perception is of the colleagues you worked with on the harmonization effort, how the interactions went. Has it been rewarding to you to do this? What's your experience of being an active participant in this process?
It's been a wonderful experience, and the international collaboration has enriched me personally, on a personal level and as a professional. And I think that's very important. It was interesting when you were discussing that you had heard from naysayers about the process. My experience has been different. So I think personally at my own institution, they hold this process in very high regard. And so everything has been very favorable in responses, sort of at the Comprehensive Cancer Center level, because they are definitely vested in the process and in the process of collaboration, and then with my own colleagues. It is very interesting to them. Some of them are on some of the parent NCCN guideline committees. And the process has been incredibly enriching. So the opportunity to actually visit Africa was also personally wonderful. I had had an opportunity to visit Kenya with one of my colleagues here at UAB, but we had to cancel that medical school visit. So the actual, just the travel for me personally was wonderful. And Dr. Msadabwe had been a visitor at UAB for several months. And so we already had an existing relationship. So the interactions just personally with the exchange of ideas was incredible. To understand the thought process, it just kind of shows you that physicians are kindred in the way that we think, in the way that probably it has a lot to do with just our personalities are very similar. No matter where you are and where you practice, you sort of have the same goals in mind. And so, and it's true. And this experience really solidified that for me. So hopefully, I just appreciate being involved. I've been a volunteer with the American Cancer Society for many years. And so I know that organization, and of course I know the NCCN. And so the collaboration is wonderful. And it was interesting when you were talking about the Kaposi sarcoma guidelines. Just makes so much sense, because I learned a lot from the colleagues working on the head and neck committee. The level of expertise there was phenomenal. So it was great.
Dr. Zelenetz, what's your experience like?
Well, we're in a instantaneous information age. I think there was a time, and it wasn't that long ago, where when we would travel, we would bring information that wasn't available to a region, but that's not true anymore. Our colleagues around the world, I have been incredibly impressed, are very up to date with what the state of the art is. Their struggles frequently are not with, understanding the data, because I think the level of sophistication and understanding of data is excellent. The struggle is, it sounds great, but I can't get that. CAR T cells, the data looks really good, but listen, we can't do we couldn't even think about doing a CAR T cell here. I've been so impressed by the dedication and the desire to try to get those results that are seen in resource-intense areas for patients locally. Okay, every physician wants to try to get the very best result possible, really, but sometimes that's really where the interactions can be helpful, because it's that experience and the exchange of experiences. One region like MENEC might have more experience with HTLV lymphomas. We have more experience with another type of lymphoma. And it's this interchange that not only helps the guideline process, but it actually enriches the personal exchanges.
And Dr. Koh, what's your experience been like?
I agree with what Dr. Spencer and Dr. Zelenetz said. It's been personally enriching. I've learned so much from our interactions. And in fact, before I joined NCCN and was chair of the service committee, we actually found ways to improve our parent guidelines, because the new perspective, if you go to sub-Saharan Africa, where cervical cancer may be the #1 cancer in many countries among women, and it's relatively rare in North America, questions were raised, well, why did you do it this way? And, sometimes in the NCCN guidelines, it was something that was started, 22 years ago, and it was there, and it gave us a new perspective. Okay, let's re-evaluate why we're doing it this way, and improve the discussion, if you will. The other thing that I've greatly enjoyed, and it's a little bit of a trite expression that there's strength in numbers, but I think that one of the things that in our sub-Saharan efforts is I've really enjoyed and appreciated the coalescence of the African Cancer Coalition. Each one of them, each of the individual practitioners, each of the individual institutions were very intelligent, very knowledgeable. But what I've seen in the past 2.5 years is the coalescence of the group, so that it has given them a sense of agency and a constituency in the global oncology phase. And I mean, specifically to Sub-Saharan Africa, Dr. Jazieh can perhaps speak to Mina. We've seen the same thing in the Caribbean, where individuals have come together and coalesce around a regional set of standards that they can agree on. I think NCCN provides, if you will, sort of that impartial broker that people can agree on and use that to build on further collaboration.
Susan, tell us about your sort of personal experience of the Harmonized Guideline process and the African Cancer Coalition.
So for me, it has been a great honor to be part of this process. Obviously, never in my lifetime would I expect to meet or interact with panel members of the NCCN guidelines. It's just something that you would look at from afar and I guess think that that's untouchable, but that's just follow what it says, but it's definitely untouchable. So for me, it's been kind of like a dream come true, something that I would have never thought I would experience. So it's been a great honor to interact with all of you guys. Yeah.
Dr. Jazieh?
Thank you. So, yeah, it was, one of the best outcome was to get our experts across borders in the region to meet together around the table, and then around common goal. And that was probably one of the initial initiative that we got us to collaborate on things. And it's because of its success, we realized that there are needs to have other collaboration to try to fill the gaps in knowledge that we have. And few things stemmed out from these interactions that came later into publication, especially recognizing the tumor profiles in our region and so on. So that's one. In terms of, it was good for our patients in the region. It's fulfilling of your mission as a physician or leader who's trying to move the field forward. So in NCCN guideline enabled me to make some difference that, that's self-fulfilling, if you will, that, you are doing a better job than, you struggle by yourself, with ideas that, may not be appealing to many people, like the NCCN guideline adaptation. So we knew better about our patients. We learned, of course, in much more depth how the NCCN guideline is made, how it's created, developed, and adjusted and modified. And then because we have to read it thoroughly, of course, multiple times, that gave us also a depth of knowledge that makes us much more comfortable, in managing, the process of adaptation and managing patients, to tell you the truth. So, because, if you are going to just work with NCCN guideline and you don't have to adapt it, you just look at the information you want and just apply to the patients. You rarely find somebody who read the guideline from, although this is my recommendation to anybody who come, the fellows, tell me what is the best source of oncology. I tell them nccn.org. That's it. Go read everything you need about that cancer there. But you rarely find somebody sit and read the whole guidelines, unless you are going to adapt it, modify it, and so on. So that gives us different level of knowledge, which is, you know, very satisfying.
Yeah, my experience when I've traveled the globe outside of NCCN institutions to work on adapting or otherwise modifying guidelines, I often find that the people outside the NCCN actually know the guideline better than the NCCN guideline panel members. It's really quite remarkable, the detail of review and critique of the guidelines that are performed. That's really wonderful. So we've heard a lot about the development of the NCCN guidelines and perspectives on the international content, the adaptations, the harmonizations, and so forth. So how do you actually go about utilizing those documents once you have them in terms of implementation? Are there programs that you have in the regions to actually increase the utilization of the guidelines? Talk to us about how you actually use them in the real world cancer care situation. And I think
so. I would say something like, should I?
Yes,
okay.
please.
So I think for us at my center, I would call them our bread and butter. So whenever you need a question answered about the management of the patient, that's what you would refer to. So in the clinic, in our multidisciplinary tumor boards, if we don't agree on something, or if we just want to check something up, that is the go-to place. If we have a query, we'll post it on our WhatsApp group. As Dr. Jazieh said, with our fellows, one thing that we do tell them is you need to download it on your device because that is your reference. Yeah, so that's how we are rolling out.
And Dr. Jazieh, how are you utilizing the guidelines in actual patient care?
So in a similar way, like Susan mentioned, you know, actually we used to have in each tumor board hard copy of the updated guidelines that in the beginning, you know, and now we have access, you know, to it virtually. All the tumor board turn out to be virtual now, but so to settle the discussion in tumor boards, you know, the NCCN guideline is the way to go. We of course have the link to the adapted guideline into the MENA NCCN website for the center. But you'll find every presentation almost in the region about any disease, almost the last slide or the slide before the last is, this is what NCCN says. This is what are the NCCN guideline to basically make the conclusion about the recommendation for that particular setting. So yeah, so it is the fact that, you know, the NCCN is just very credible and a trustworthy source. It made the, you know, the product that comes out of it easily is sellable to people. You know, you don't have to spend a lot of effort to convince people to take the recommendation. You know.
May I ask a question about implementation? I mean, the primary use for guidelines is because we want patients to get optimal care, right? The evidence base, and we know that guidelines concordant care has been shown multiple times results in better outcomes. Whatever the outcome measure is in terms of survival, tumor control, decreased complications. But do you see a day where the adapted guidelines or the harmonized guidelines might be used in a way that NCCN guidelines is used in the United States to help encourage determination and to address some of the burdens of, you know, and perhaps this is not yet true in other places, but in terms of approval of care coverage, you know, pre-authorization, because that's certainly one of the issues that is addressed in the United States, and we're working on ways to reduce that administrative burden. That if it is per NCCN guidelines, we would like to see that you don't have to have the pre-authorization or the denial, applications that we have to all go through.
Are you asking?
Yeah, I'm asking about, certainly in the global arena. Yeah.
Actually, this is, it's going to be very credible resources to have for any government or third party or anything to adapt. Now whether we are going to have, we have to be careful about this issue, because sometimes when you have a big body, a governmental body, may be slow in moving the recommendation forward. But I would imagine that if we are going to do it, they are going to take the adapted guideline, or they will take the parent guideline and they adapt it at a governmental level. So each country may develop their own subcommittee, if you will. And that's actually something that is on the table. We have been thinking about it, that, whenever a government wants to do that, we will be trying to create a subcommittee from the MENA NCCN Coordinating Center that help that particular country. So, but likely, they are going to do the government agency likely will be either taking the guideline, the adapted guideline as they are, which I doubt. They will be doing other modification because they are looking at a bigger picture. And when the government take a guideline, they have to put the money behind it to pay for it or not to pay for it. So they may be looking at it different than me and my teammate looking at providing the best care for our patients without health economics too much into the variable. So probably government has to do health economic issues, HTA in play roles and so on. So it's going to be much more complex than taking our guideline from the shelf and say we adapt it for this Ministry of Health, for example.
Okay, so we've got about 20 minutes left. So I'd like to transition now to address some of the questions that have been submitted from the attendees. And if you are in the attendee group and have a burning question that you want to ask the panel, please use the Q&A system to go ahead and ask that, and they will in turn get it forwarded to me. So one of the questions relates to COVID-19. Clearly, COVID-19 has set oncology practice on its side over the last half year or so. And we continue to have great struggles with it here in the United States. So how has COVID-19 affected cancer care within Middle East, North Africa, and Sub-Saharan Africa? And have you developed special resources to assist in cancer care during the COVID pandemic? And Dr. Susan, please.
Yes. So in our institution, we did have to adapt in many ways. For instance, I'll give an example of, okay, let me just start by saying already we have a very high radiation machine patient load. And with COVID-19, we saw it imperative to try and find ways to reduce the machine patient load. So one way that we thought of doing that is to start offering more hypofractionated courses of radiotherapy to some patients who we believed would not really benefit from the longer courses of radiotherapy. Also, for instance, protracting the time that we would need to treat the patient, for instance, in prostate cancer, for example, would give more neoadjuvant ADT before putting them onto the machine. The example that I'll give for hypofractionated courses is more hypofractionated courses for cancer of the breast, so that we reduce the machine load, as well as for the later stages of cancer of the cervix, as well as being more prudent with how we actually utilize radiation resources. For instance, a patient who we would be considering treating radically, but maybe they've just passed that bar of being treated radically, we would consider treating palliatively if we feel that the benefit is not as great. And also another way is we actually started having, instead of, so we decided that we would not delay seeing any new patients, so we continued seeing all new patients. However, for the follow-up, so these are people who have been treated before and maybe are in remission, or instead of them coming for follow-up, we actually started doing telephonic interviews rather than them coming into the hospital, so like a telephonic review. And some of these things are actually things that we think even past COVID-19 are beneficial, both for the resources as well as for the patient. So that's just a couple of examples.
Yeah, so if I understand the question, so we have done many of these things, but I think probably the questioner is asking about NCCN itself. I think the activity we have done in our region about the COVID-19 was not NCCN based thing, but NCCN, I just want to alert people that NCCN has terrific resources for COVID-19 management. They have one guideline, but they have listed all the other resources that you can access for oncology to manage cancer patients with COVID-19. So for the questioner who asked about NCCN did not develop guidelines about COVID-19, actually there are a lot of resources in the website of NCCN about COVID-19 managing in cancer. And you know, even all these guidelines, by the way, I will not even call it guidelines. You know, the managing of cancer patients during COVID-19 was shooting from the hip most of the time, actually. You know, this is how we are done. This is what you should do. There's no evidence. So these are recommendation, if you will, was put by different entities, and you know, it would not reach the level of being guidelines. But I just want to emphasize that the NCCN has great resources for COVID-19 management of cancer patients.
Great, we certainly do, and they're found on our website at nccn.org/COVID-19, and they do include sort of institutional best practices for safety for patients and staff, how to organize sort of a rapid response organization or team to a pandemic sort of a situation. How do you communicate? How do you organize? How do you set that system up? As well as some of our panels have made recommendations about how within the COVID-19 pandemic to prioritize therapy, much the same that Susan has talked about in terms of what are things you can delay, do remotely, what are the things that you really need to prioritize and just do now in the patient's best interest.
This cumulative experience of how to adapt the guidelines, it becomes handy, you know, it becomes handy in such crises, because you are all of a sudden encountered resource challenges that you have to really roll with the punches, and you know, you have to know how to do the adaptation. So
we have a question about, are there local reimbursement considerations for the creation of adaptation of NCCN guidelines? And also, how does NCCN consider metabolic differences in populations? And do we evaluate ethnically specific subpopulations in clinical trials? So actually, it's a series of 3 questions. Let's start with the one about you know, how are financial implications and reimbursement considerations considered as we develop the International Library of Guidelines?
Very simple for us. You know, we have stuck with the best recommendation. We did not do the you know, the cost effectiveness or health economics issues. We left it, you know, out of the equation for the adaptation in our region. But as I said earlier, each institution has to argue their point. So whenever I want to add a medication based on the NCCN guideline, I do pharmacoeconomic studies and I say, this is the guideline, this is the cost effectiveness of this medication into this, and move on. But you know, the fact that it is in the FDA approved and then in the guidelines is one of the basic requirements. Without this, you cannot move even to the P&T committee and recommend medication to be added to the formulary.
And Dr. Msadabwe, how have the Harmonized Guidelines panels dealt with differences in reimbursement from country to country, or even within regions within a country, or have you?
I can only speak for my country. The thing with my country is at the moment, there's no what we call health insurance. So there's no such thing as reimbursement. So what we recommend for the patient as an institution is what we would give the patient, whether it's available or, well, usually the patient can't even afford to buy anything. So it would usually be what we would give them. So in our setting, not yet much. And I believe in most other African countries, health insurance is quite minimal. So yeah, but it's something that we'll have to consider as we go along.
And there's a question about, does NCCN consider metabolic differences in populations? Anybody want to respond to that one?
Yeah, we did, and we find, as I told you, earlier, that we find that we really don't know many facts about, the prevalence of certain targets in our population. And we have done multiple studies across the countries and published actually like 3-4 papers, and there's other one coming, the prevalence of different actionable targets in lung cancer, at least. And that's why some of the recommendations of not to switch the treatment to target therapy as early as possible, because there's a large portion of our patients, up to 30% of them are positive, for example, for EGFR. And we did not want this large number of patients to miss the chance of getting the TKI as early as possible. So that was based on what we know about patients' population. And then in the earlier phase, before we move away totally from not recommending anything without next-gen sequencing, if we did not know patients' EGFR status, unknown, not the wild type, we would recommend in the past to treat with TKI blindly, because you have 30% chance of hitting the target. But now we are moving to making sure mandatory is being done. The next-gen sequencing, or at least the common actionable targets.
Yeah, so that's the difference, not only in not only metabolic differences, but genetic differences and target differences. I do remember probably 15 years ago working to adapt the breast cancer guideline for use in China, and the Chinese physicians who were working with us as a group, all of them said, we can't use the doses of anthracyclines that you all use in adjuvant therapy because our patients just can't handle those doses because of metabolic differences. And so in fact, we in that guideline reduced the dose of doxorubicin and AC chemotherapy to a dose that the Chinese physicians felt was safe for their population. And subsequently, there have actually been some metabolic studies published that showed that their empiric experience was borne out by differences in metabolic handling of the anthracyclines. So again, a situation where we can learn from the international experts about how to optimize therapy.
We have that in the pain management that, our pain experts said we cannot start in opioid naive patients, for example, of 10 milligram of morphine will knock them out for 3 days or something. So we have to modify the initial dose,
Yeah, I good points. But fortunately, I do think that a lot of the biomolecular measures are generalizable. We do know, for example, that while there are differences, EGFR aberrations in non-small lung cancer mean more similar things, or HER2 positivity in breast cancer means more similar things. This is a challenge even in the United States, as many of you know. We do know that clinical trials have not included enough of the minority racial populations, and I think that we are looking at trying to address that. For example, Black Americans have not been sufficiently represented in the clinical trials, and they do have biological differences, things like creatinine clearances and stuff, which may, or different body mass index distribution that may have excluded them from the clinical trial. So we do have to do a better job, not just in a global sense, but in the clinical trials that we run in the United States, and then accommodate the differences on a global setting.
Great. So a really important question, I think, for the audience that's with us today just came in, and it's, how can the pharmaceutical industry play a more effective role as a partner in raising the awareness and high standards of cancer care from a scientific and educational perspective? So what role can the pharmaceutical industry play, or should they play, in trying to improve the quality of cancer care and accessibility to cancer care globally?
Can I start with that? So actually, pharmaceutical industry are critical and important partner in improving the cancer care. And, I think they have multiple roles they can play to enhance the cancer care, starting with trying to include as much as possible patients from the regions, in the clinical trials that are available, and try to capture as many even post-marketing data about how the medications perform in this population. So that's number one. Starting from the beginning, try to get as much information as possible about the particular population. That's number one. Number two, unfortunately, we find that many of the risk sharing and programs offered in developed countries are not available in certain countries. So at least make sure that they do that and offer to patients, because that may help help us reach certain population, or at least larger population, that we can have the medications available for them. And the third important thing is that to be cooperative in terms of helping the institution of providing, or the HTA, if you will, providing data that that's related to health economics, pharmacoeconomics, and so on, and be cooperative of trying to make sure that they strike a good deals with these agencies to make sure that they give access to as many cancer patients as possible. In the risk sharing scheme, there is a lot of things that they can do, including individual patients' assistance, including. So it starts from including these patients in their studies, all the way even post-marketing expanded access program and so on and so forth, to offering the access to their medication in the most feasible way that they can do to the different population, to cooperate with the official agency and entities, making sure that we do a good, reasonable pharmacoeconomic studies that make the drug available to more people. I hope that answer at least some of the critical points that you expect from the industry.
Anyone else want to comment? So there is an effort that's being spearheaded by the Clinton Health Access Initiative and the American Cancer Society that's part of the broader initiative beyond just harmonized guidelines in sub-Saharan Africa. And it's a system where participating pharmaceutical companies are offering for use in sub-Saharan Africa and purchased by cancer centers or health ministries and so forth, steeply discounted anti-cancer agents. The discounts are very substantial, and there's a growing list of companies that are actually participating in that effort, and therefore a growing list of agents that are available. And you know, guidelines are one aspect of cancer care, but there's also, you know, pharmaceuticals, there's a need for radiation therapy, there's need for education of experts and continuing education of experts in terms of new therapies and so forth. And those are the sorts of things that the pharmaceutical industry is really good at. And so, you know, those efforts, either, you know, by individual companies or in partnership with organizations like NCCN or, you know, Middle East, North Africa, NCCN, or the African Cancer Coalition, you know, those are organizations that can work with industry to provide access to therapies and to do educational activities as well. So I think there's a whole lot that industry can do.
Yeah, there is sorry, Bob, did I interrupt you?
No, you did not.
But I want to give a very real world experience actually with the industry partnership that, you know, with partnership with industry, we are able to do next-gen sequencing for any patients with lung cancer in Saudi Arabia, you know, and you know, by this, we don't have to struggle, you know, with each individual patients, wherever they are, to do next-gen sequencing to find whether they have targetable, actionable targets or not. So this kind of partnership actually changed the care in the ground, because, you know, once you discover there is a target, actionable target, then you are, you know, going to take the next step to manage the patients properly. And, you know, although we started with one company, but, you know, now it's going to be a consortium of companies. And I think it's done also in Latin America, where multiple companies come and they say, we are sponsoring the next-gen sequencing for cancer patients through program, official program. It's like a legal agreement and so on that, you know, will be done, you know, to help the cancer patients in particular country. And so that's very important partnership that changed actually the care, you know, in the ground dramatically.
So not to overstate the obvious here, but the guidelines are central, however, to pharmaceutical participation. When they can approach a region or, you know, and say, oh, we know that care is going to be relatively uniform, this is what's being recommended, then they have a basis, you know, the local pharmaceutical folks can go back to the parent company and say, listen, this is now going to be used standardly across the region. You know, we have an obligation now to try to help, you know, these drugs be used. And, you know, we're going to get some backing because they're in the guidelines. So, you know, there is a very important synergy between the guidelines and then what the pharmaceutical industry can do on the basis of what's in the guidelines.
Excellent point. Excellent point. Well, we've come to the end of our time. I'd like to thank Dr. Abdul Rahman Jazieh, Dr. Sharon Spencer, Dr. Wui-Jin Koh, Dr. Susan Msadabwe, and Dr. Andrew Zelenetz for sharing your expertise and perspective with us today. And with this, I will turn it back over to Tracy.
Thank you. Thank you very much.
Thank you, Dr. Carlson, and thank you very much to our panelists. We hope you enjoyed today's panel. We thank you all for attending. This session has been recorded, so after, in a few days, we'll be sharing a link with that for you and for anyone on your team who may not have been able to join us today. I'm sorry we weren't able to get to all of the questions, but we've taken note of them and we hope to get you answers in the coming days. Again, if you have any additional questions, my name's Tracy McDowell. I'm the Manager of Global Business Development at NCCN, and you can email me directly and I'd be happy to triage those questions for you. If you have any further information about these NCCN global initiatives you've heard about today, or our NCCN Global program in general. It's growing constantly. We look forward to new collaborations in 2021 and more offerings. Please reach out to myself or my team. We'd be happy to help you. Thank you again for attending. Please keep up to date with our e-bulletin, global e-bulletin. If you haven't been on it yet, please email me and I'd be happy to send it to you. We'll have a lot of new global programming ahead of us in 2021 that we hope you can partake in as well. So again, thank you everyone for your time. Our panelists, we really couldn't do it without you. Thank you, and thank you to Dr. Carlson for moderating. We've greatly enjoyed today's session. We thank you for attending and have a great day, everyone. Thank you. Goodbye.